Okay, we might make a start. I would like to say good morning or good evening or wherever you are in the world, whatever the time zone is. It's lovely to have you with us. My name is Claire McCann and I am one of the editors-in-chief of the IJLCD. And along with Jill Titterington, who is also on your screens, she is the other editor-in-chief. We're hosting and would like to welcome you to this annual winter lecture. And of course, we're delighted to have Professor Jo Patterson, who's going to be speaking to us. I'll introduce her shortly. But before I do, I just wanted to run through some housekeeping with you. The first point to note is that this is being run as a webinar. So unlike a traditional Zoom, you won't be able to use the chat function in order to ask questions. We really want you to use the Q&A button, which of course you will see. Depending on your version of Zoom, it might be on the bottom or the side of your Zoom screen, but the Q&A button will be where we're encouraging people to ask questions, and those questions will be answered at the end when we get to the Q&A section of the webinar today. Of course, the chat is there, but everybody will be able to see your chat. That would not be the place to indicate any questions you have about the content. Please only use that for technical queries. And Justina from the Royal College is available and will be able to help out with any technical queries, but she won't be speaking today. She'll be doing that magical job behind the scenes, which is going to help it all run so smoothly. As you know, it is being recorded, and the point of the recording is so that people can have access to it afterwards. That will be available on the Royal College website, along with the slides. So Professor Jo Patterson has given permission for her slides to be made available as a PDF document for you, which will be available after the seminar, the webinar today. May I have the next slide, please, Hannah? Thank you. Immediately after the presentation, there will be time for Q&A. We hope we've left a good amount of time for questions and answers today. If you're anything like me, it takes a little while after you've devoured and understood all of the content before you can come up with questions, but literally feel free to pop them into the Q&A section of the webinar when they come to mind, and we will be addressing them at the end. Many of you have also provided questions when you registered, so of course they will also be answered as we're going through. And the only other very important piece to let you know is that there is an evaluation immediately after the lecture today, and we will have a little bit of time available where you can access the evaluation from using the QR code. And it will be really important for you to fill that in and give us any information that you can so that we can improve future events. And if you've got suggestions for other topics to cover in future annual lectures, we would be delighted to hear those as well. May I have the next slide, please? Thank you. Moving on then to talk a bit more broadly about the IJLCD, the International Journal of Language and Communication Disorders. This is a journal that is published by Wiley on behalf of the Royal College. It's an open access journal. Hopefully you're all able to access it in your workplace. It is published bi-monthly, so 6 times a year, and it includes a wide range of articles for those of you who are not quite as familiar with it. Of course, it covers quantitative and qualitative research across the lifespan, looking at speech, language, communication, swallowing, and pretty much every area that's associated with day-to-day speech and language therapy practice. We do have Jill and myself as the editors-in-chief. Jill has a pediatric focus. I have more of an adult focus. And we have a team of associate editors, which are demonstrated or displayed for us on the next slide, please, Hannah. And our team of associate editors, they cannot all be here today at the lecture, unfortunately. So they have willingly sent photographs of themselves so that you can see who they are. And we've got some that are more focused on pediatric submissions and articles and manuscripts, and others that are more associated with adults. And of course, there are some people like Lottie who actually covers a bit of both in the specific articles and manuscripts that she handles. You will see there is a square with or a rectangle with a question mark in it. This is because Jill's going to be speaking shortly about a new associate editor position that we have. It's a vacancy that we have. May I have the next slide, please? The other thing that I have the joy of mentioning to you very quickly is about the IJLCD podcasts. And this is where about 4 times each year, we will highlight one of the research, one of the articles that's been published in the IJLCD, and have a bit of a conversation with the researchers who produce that work. And it's a 25, 35-minute podcast. And it's a pretty easy listen as you're walking the dog or catching the train to work, however you access your podcasts. And it's designed to really highlight some of the research that is published in the journal and to give you a little bit of a taster of it so that you've got some insights as to whether or not you want to access and read the article. It's available across 2 platforms. The Royal College podcast, or the Royal College website, has a tab for podcasts. It's also available through Spotify, and you can download and create your own playlist through Spotify and access them that way. And now I think, am I handing over to Jill for the next slide? Yes, I am. Thanks, Jill.
Thank you, Claire, and very welcome, Professor Patterson. We're really looking forward to hearing this exciting lecture this morning. Welcome, everybody. Just a few things from me. As Claire has said, we have an opening on the journal's editorial team for a paediatric associate editor. I'm just going to post the ad into the chat there for you. The closing date's the 20th of February. If you're interested or you know of people who may be interested, please do share the information, and we hope to have the interview sometime the week beginning the 23rd of March. Next slide, please. Just a brief moment to talk about an exciting project we're doing as part of the IJLCD work, which is to look at developing a peer review training scheme. This is specifically for research champions. And it's going to involve online learning and mentoring to support research champions who are interested in becoming peer reviewers for the journal to join us in that work. We're in the planning and development stage at the moment, but we hope to launch it later in the year. So if you're a research champion or interested in becoming a research champion and interested in becoming more involved in the journal, please do keep an eye out for how things develop there. Thank you, and I'll hand back to Claire.
Thank you, Jill. Sorry to have dominated the webinar. You obviously haven't come to hear Jill and I speaking. So it gives me great pleasure to warmly welcome Professor Jo Patterson, who's going to be speaking to us about her work. And clearly you are all interested in hearing from her. So many of you will know that she's, of course, the chair of speech and language therapy and the vice dean for research at the School of Allied Health Professionals and Nursing at the University of Liverpool. Jo is a very experienced researcher and clinician, having spent many years in both roles, and has a very broad and deep research history with well over 200 peer-reviewed publications and book chapters. She's also a senior investigator on some funded research projects, a fellow and professional advisor for the Royal College, and has a really extensive experience and history, and we're absolutely delighted to have her with us today. In lead up to this, I was asking Jo if there was anything about her that people may not know that would be useful to add as the part of the introduction, so that she feels accessible and human to us, despite having such an extensive work history. And Jo said, well, no, not really anything. And then I did my own digging and found out that she did spend some time working in New Zealand, which is where I am based, and has a good friendship with some of my colleagues and friends here in New Zealand. So speech and language therapy world is very small, and wherever we go in the world, it's lovely to be able to make those connections and to reach out. So on behalf of everybody today, Jo, thank you so much for being with us, and we're absolutely delighted to have you speaking to us and sharing your wisdom and knowledge. And I'm going to pass over to you.
Lovely, thank you very much. I will now attempt to share slides and keep fingers crossed. Okay, is that working, people?
Yes, lovely. Thank you.
Very lovely. Well, first of all, thank you so much for that warm welcome, Claire. And I just wanted to say what a privilege and honour it is to have been invited to give this talk for the journal as part of their winter lecture series. I was really thrilled to get the invitation, so thank you very much. I know the journal has been a great resource, not only for the standard of the articles that it publishes, but also it's such an important channel to get research out to the people ultimately who we hope are using it in the clinical setting. So thank you very much. So just to give you some more background as to who I am. Obviously, I'm a speech and language therapist. I qualified in 1991, and very early on, I became involved in working with head and neck cancer patients, and I've remained in this clinical area for across that career lifespan. It was probably until it wasn't until 2005 though that I became more interested in research, and in actual fact it was my time spent in New Zealand that really got me interested in this area. And so from 2005 onwards, I started to blend academic short-term contracts with my clinical work across Sunderland Royal Hospital and Newcastle University. And then in 2020, I took a leap of faith and switched to the university sector full time whilst maintaining some clinical input. And as mentioned, I'm hosted by the School of Allied Healthcare Professionals and Nursing. But what really galvanised me to move into this new setting was the development of the Liverpool Head and Neck Centre, which was a vision of its director, Professor Terry Jones, who really saw the need to blend academic and clinical units together to optimise patient outcomes, delivering and developing cutting-edge treatments for our patients. And then last year, the icing on the cake for me really was to be awarded the National Institute for Health Research Senior Investigator Award. And this is the first time that this award had been given to a speech and language therapist. Now, as part of that role, I'm charged with being an ambassador for the NIHR. And for that reason, I'm going to hijack a couple of the slides right at the very end, just to go through what the offering is from the NIHR and how we can capitalise on that as speech and language therapists. So the main thrust of my talk today is about head and neck cancer, about evolving treatments and how we may respond to that in advancing our rehabilitation. But just to set the scene to begin with, the number of cases of head and neck cancer is rising, not just in England, but globally. And currently it is the UK's 8th most common cancer. Every year, over 13,000 new cases are diagnosed and over 4,000 deaths occur. So head and neck cancer is an umbrella term of cancers that arise in areas such as the larynx, different positions in the pharynx and the oral cavity, or it may simply just present as a neck lump. So the risk factors traditionally have been risky alcohol intake and tobacco smoking. But in the last 20 years, we've seen a rise in the number of human papillomavirus associated head and neck cancers. And you have probably read about this in the media. We know that there are a number of high profile people that have been diagnosed with this disease. And that has meant that the demographic has shifted as well, because this HPV associated head and neck cancer is more likely to occur in younger adults who may not have engaged in alcohol and smoking. So the risk factors, this is a disease that predominantly affects males. About 80% of our case group are males, although more recently we've seen a rise in the number of females diagnosed with oral cavity cancers. But there's also been a steep rise in the number of older adults diagnosed with head and neck cancer. And that might reflect our ageing population overall, but clearly this group are going to present with more comorbidities. They often come to us with more advanced head and neck cancer. They're more often living alone and may have a lower income. What hasn't changed over the last few decades, though, is that the incidence of head and neck cancer and mortality rates are associated with areas of deprivation. And we can see here in this map that actually the highest number of our patients are living in the north of England and the northwest of England. So this is a disease of deprivation, and therefore it is subject to huge health inequalities. So the treatment for head and neck cancer can range enormously. So more advanced head and neck cancers may be treated by complex surgeries and reconstruction techniques. But also we have non-surgical treatments such as radiotherapy with or without chemotherapy. And because this disease arises in specific anatomical areas in the head and neck that are responsible for function, then this is going to impact enormously on patients. So we know that a lot of our patients will present with profound swallowing difficulties and alterations to their speech intelligibility or their voice quality. And that impacts on how they live their lives, how they spend their time, and getting back to activities of daily living. So it's not surprising, therefore, that this disease is strongly associated with poorer quality of life outcomes, higher and more profound than that with other cancer groups. So here is a bar chart that just illustrates the number of concerns that head and neck cancer patients present with. And this is a mashup of data, of global data, and it shows that there are numerous symptoms and problems that our patients come to us with. But 3 out of 5 of the top 5 of these priority concerns are related to chewing, eating, swallowing, speech and voice. And so speech and language therapists form the cornerstone of really trying to optimize life for head and neck cancer patients after treatment. So that treatment comes with additional challenges, though. So one thing we know about our head and neck cancer group is that they have very high rates of anxiety and depression, much higher than other cancer groups. And often there's a high degree of loneliness, and they have more suicidal ideation than the general population and other cancer groups. And of course, this presents as a challenge in order to engage people in their rehabilitation. As already mentioned, this is a disease where people may be coming from low socioeconomic backgrounds, and what is associated with that is poorer levels of health literacy. So these individuals may find it much harder to work their way through healthcare systems, to access services, and really integrate the information that we are giving them around treatment and expectations. More recently, our service delivery has demonstrated that actually a lot of our head and neck treatments are delivered in specialist centres. And I'm just directing you to the GIRFT programme report, which stands for Getting It Right First Time. And this demonstrates actually that many of our patients may be living at some distance from the specialist centre. And so this presents challenges for us, particularly for those patients that may be living rurally or at some distance away, and how we deliver rehabilitation to them. So all in all, in terms of the incidence and the treatments, we are seeing a much higher number of head and neck cancer survivors, and that also presents challenges about how we deliver and ensure that there's equal access to high quality rehabilitation services. Over the course of time, I've certainly seen an evolution of treatment for head and neck cancer. And when I first started out in the 90s, the main sort of treatment that the patients that I was seeing were really quite substantial surgical resections and reconstruction at that time. But when it came to the end of the 1990s, we began to see the development of what was then termed organ preserving treatment, where radiotherapy was combined with chemoradiotherapy to offer equitable cures for head and neck cancer. So there was a switch. And of course, this appeared preferable because it didn't mean that patients had to endure large surgical resections. However, it soon emerged that this treatment had major issues for function. And I'm just going to roll a video fluoroscopy of the first patient that I saw having had chemoradiotherapy for a large base of tongue tumour. And we can see here that he has got really quite profound swallowing difficulties, gross aspiration, and problems with efficiency. And he was unable to swallow after his treatment and remained PEG fed for the remainder of his days. And for him, he was really not expecting this as a side effect of treatment and was devastated by this loss. And that galvanized me into exploring this via my PhD. However, things have evolved over the course of time, and radiotherapy techniques have become more refined. We saw the development of intensity modulated radiotherapy, which was aiming really to reduce the amount of radiation that the healthy tissues were receiving and hopefully minimizing the impact thereafter. And this was then developed into what's now known as dysphagia optimizing IMRT, which is really looking at trying to shield those structures that are critical to swallowing function. But unfortunately, radiotherapy is the gift that keeps on giving, because now what we're seeing clinically is that patients are returning to us some years after radiotherapy because they are experiencing increased levels of fibrosis and scarring, which then leads to further deterioration in their function. And I'm going to return to this topic later on in my talk. So not only has radiotherapy developed, but also surgical techniques have developed. And over the last decade, we've seen the introduction of minimally invasive surgery. And you've probably read about robotic surgery coming into the operating theatre, which has really altered what we can offer patients, particularly for those with smaller stage disease, lower volume. And of course, part of this development was to try and reduce the functional impact that patients were experiencing. So one of my colleagues, Sarah Stephen, has looked at the functional impact of this treatment on function and is currently conducting her PhD with us in this area. But this systematic review identified that actually, although 3/4 of patients didn't present with dysphagia at baseline, in the early period post-operatively, 1/3 of them were aspirating, and there was readmission to hospital in up to 8% of patients. It identified that patients with tonsil disease, higher levels of tumour volume, these things were predictive of swallowing outcomes. it emerged that improvement was seen around sort of 6 weeks, but by 1 month, about a fifth of patients still had moderate to severe dysphagia. And of course, this has implications for us in terms of rehabilitating this particular group of patients. And then finally, in terms of the treatment, another really exciting development has been in the field of immunotherapy. Particularly for those who come back to us with recurrent or metastatic disease. Now, traditionally, those patients that were deemed to be not for curative treatment on a palliative care pathway, they were largely given a life expectancy of approximately 6 months. But of course, with this new development, we are seeing that patients are living longer with recurrent disease. And of course, that means that they are going to have functional problems for that period of time. So again, that adds to our caseload. So all in all, taking all of those things into account, we can see that actually there's a rising need. And also that means that there's could be a big gap in what we can provide in terms of our rehabilitation. So what I'm going to move on to now is how we may be addressing those challenges and with the underpinning evidence base to support that. So I'm going to take us through various points in the head and neck cancer care pathway, look at what the challenges are and help to provide further direction. So I'm going to start with the pre-diagnostic phase because there's been substantial developments in this area. So one of the issues that I think is perhaps a global issue is that the number of referrals coming through to us with suspected head and neck cancer, certainly in the UK, is well over 200,000 referrals per year. And so that's a huge demand on services. And here we have what's known as the 2-week wait target set by the government. We know that approximately 10% of our patients don't get seen within 2 weeks. And furthermore, 97% don't have cancer. And so we may be raising anxiety being on the 2-week wait, but also we're seeing a lot of patients for whom they don't actually have cancer. So one of my colleagues, Professor Vin Polleri, based at the Royal Marsden Hospital, developed and refined a risk calculator, an algorithm that helped to better identify those people that were at risk of head and neck cancer. And this is now being developed into a large programme grant, which I'm working with him on, that is looking at refining a patient-reported symptom-based risk stratification programme. But with this has come opportunities for speech and language therapists to become involved and to lead on low-risk clinics for those patients that are presenting with voice changes or swallowing difficulties, and using our expertise to extend our role. And this is the area that one of my colleagues, Louise Ockamore, is working on currently and conducting a PhD in, working alongside this large trial. So in the build-up to this work, we probed a little bit further into looking at what the attitudes of this shift in role for speech and language therapists might mean. And our first paper was conducting interviews and surveys with speech and language therapists to get their take on it. And I've just extrapolated a couple of points from this paper. They identified that currently there's very little recognition of our profession taking part and doing this type of work, so it can be hard to establish our credibility in this area. There were concerns about accountability as well, and that it could only work if consultants were willing to work in a true parallel clinic as well to support our role. We also conducted interviews with ENT surgeons to see what they considered was important about this model of care. And they recognised actually that speech and language therapists were extremely meticulous in the way in which they assessed the laryngopharynx, and they can pick up things that even consultants sometimes don't recognise. They thought it was a highly cost-effective service model, but also they recognised actually that the protections are non-existent for when things don't go according to plan, and for example, a head and neck cancer that is missed. So Louise is now currently working on looking at what the training needs are and what the competencies might be around this. So we look forward to that, the results of that work. So I am now going to move on to the pre-treatment phase and what we can do to optimise this too. So in the pre-treatment period, patients are often presented with information, and part of our role is about setting expectations and maybe facilitating shared decision making. But in terms of the research currently, speech and language therapists have been involved in a really large internationally based trial called Pathos. And this is led by Cardiff and Liverpool. And this trial is really looking at those patients for whom they're treated by the minimally invasive surgery with HPV positive disease, and we are looking at whether if we de-intensify the adjuvant radiotherapy, whether that will result in improved swallowing outcomes. And I'm working with colleagues on this trial to really look at what those swallowing outcomes are. And this means that speech and language therapists have really become very much involved in delivery of research across 37 centres in the UK. And there are other centres in the States, Australia, and across Europe that are conducting this research. And it has just completed recruitment of over 1,000 patients. So we are delighted with that outcome. So by planning the treatment and tweaking the treatment from the outset, this may improve functional outcomes. Another area that speech and language therapists are involved with is in the arena of prehabilitation. So this is about optimizing patients before they go through what can be very aggressive treatment. Prehabilitation has 3 pillars. It's concerned with eating, drinking, and nutrition, physical exercise, and psychological support. So obviously for us, we are concerned with the eating and drinking component. So a few years back now, a group in Texas at the MD Anderson Center published this research which showed that if patients were given what's called prophylactic swallowing exercises and they were encouraged to continue eating and drinking throughout radiotherapy, then this improved dietary outcomes at 1 year. And so this was built on retrospective data, but it sparked certainly the concept that we could prehabilitate the swallowing mechanism. But that came with challenges. Contextually, within the UK, a lot of our patients were receiving what's now called a prophylactic gastrostomy, and this was thought that if patients received this before they started on radiotherapy, then it was hypothesized that they may stop eating and drinking earlier into their radiotherapy, and therefore the swallowing mechanism was underutilized. But of course, to keep people swallowing and eating and drinking during treatment and exercising is problematic. And that's because the side effects are so profound. And I think this is really encapsulated in this patient quotation, who said, "I was in agony. I could have given up 2 weeks in. eating was like putting acid on a fire. So really, it was difficult for patients to adhere to this treatment. So since that time, there have been numerous systematic reviews, scoping reviews, literature reviews, and all of these reviews have kind of concluded that actually there's not strong evidence either way for the effectiveness of this intervention. And that's not surprising because the literature has several weaknesses. So what these reviews have found, that actually there's a range of different protocols, there's different exercises that people were giving. The control groups were very often poorly described. There were difficulties in adherence, as we've seen, and also a range of outcome measures. So it was very hard to synthesize this evidence. But it's really this adherence that is a big block. So if you can't, if patients can't adhere, it's really problematic to see whether this is effective. And here in the UK, my colleague Rogani Govinda has really tried to progress this intervention by engaging with behavioural change techniques to support patients to adhere. And this has recently been published looking at a pilot randomised control trial. However, more recently, we have seen evidence that has been published in an American and Canadian collaboration, which has really produced high-level evidence in this area. And this study has now just an abstract form in terms of its results. But it compared reactive treatment. So if patients were identified as having dysphagia during radiotherapy, then they were given high intensity swallowing exercises. That was compared with low intensity intervention, which was just dietary advice and goal setting, compared with prophylactic dietary advice, goal setting, and swallowing exercises. And the primary outcome measure was the length of time that the patient had a feeding tube, as well as some secondary outcome measures. So here is the results in abstract form. So first of all, this trial managed to recruit just under 1,000 patients across 13 sites, which is a great success. It noted that about half of patients didn't have dysphagia to begin with. And the mean number of days with a feeding tube was hovering around 35 days. But it didn't find any difference across these 3 intervention groups for the length of time with a feeding tube, patient-reported outcome measures, diet or weight. And the next steps will be some sub-analysis looking at video fluoroscopy. So the authors and the leaders of this trial have come up with some interim guidance for this. They say that actually it's still important to do a baseline speech and language therapy assessment with video fluoroscopy, that we continue to monitor during and after radiotherapy, and if dysphagia is identified, then to rapidly deploy swallowing therapy in order to try and reduce the long-term impact of this. So I am now going to go back to our care pathway and talk about what we can offer during treatment. And I'm really, again, going to focus on radiotherapy treatment. So as already suggested by the trial, it is important that we continue to monitor patients whilst they're having radiotherapy for an early pickup of problems. And during my PhD, I collected data and evaluated a simple swallowing test called the timed 100 ml swallow test that really helped to provide normative data and also look at meaningful change and how to pick up deterioration in swallowing. But also we have other patient-reported symptom questionnaires that are quick, such as the EAT-10. And also we have dietary scales where we can pick up the presence and the need for alternative ways of feeding. But in order to combat the number of patients that we have on our casebooks, then clearly we need to engage with other professional groups as well, or train up some of our speech and language therapy assistants in deploying some of these evaluations, and also find different ways of either the patient self-evaluating or finding ways, thinking about IT and new technologies in order to log this type of data. So I'm now going to move into the follow-up period and what speech and language therapists can offer here. And perhaps over the course of time, I think the clinical excellence networks have really helped to galvanise us in this. It's important that we come together and ensure that we're trying as much as possible to develop a core outcome set so that we can compare as treatments sort of evolve as well. And I think largely by looking and developing the guidelines, which I've highlighted here in the footer, that we have now a number of different outcomes that I think collectively will be common to us in head and neck cancer. So for our instrumental swallowing assessments, then videofluoroscopy and FEES remain perhaps the cornerstones of this evaluation. And more recently, we've been involved in work that has helped develop what's now known as the Digest scale. And this is a summary measure to give a sense of swallowing performance across both of these instrumental tests. We have clinical measures, as already mentioned, that we can use at the bedside or in our clinical consultations to monitor patients' performance and pick up problems earlier on. And also we have patient-reported outcome tools as well. And perhaps more predominantly, this is the MD Anderson Dysphagia Inventory, which is perhaps the most commonest questionnaire that is used in this case group. So in terms of our dysphagia therapy, well, reflecting back, Jerry Logerman was obviously such a pioneer in the arena of developing dysphagia therapy, and often her earliest research came from work that she published on working with head and neck cancer patients relating to both swallowing exercises and manoeuvres, and that still remains part and parcel of our toolbox these days. But things are evolving in this area. So one thing to mention is the intensity in which this dysphagia therapy may be offered. And this is an example of just a paper that talks about using a boot camp style of delivery. So really intensive periods of swallowing exercises. And this is shown to help improve diet, but perhaps not so much swallowing safety. We also have devices such as the expiratory muscle strength trainer, and this theoretically can help with laryngeal elevation as well as the ability to improve cough function should anything be aspirated. And this is evidenced by case series and pilot work. And then we have another treatment that focuses on respiratory swallow training and really trying to improve coordination in this. And this is a technique that was pioneered by Bonnie Martin Harris in Chicago. And my colleague, Dr. Michelle Lawton, is currently trying to bring this more into the UK clinical setting. And then we have other techniques. This is a focus on the adaptation, the psychosocial, addressing the psychosocial needs of patients alongside swallowing impairment. And this was the focus of my postdoctoral work, with combining cognitive behavioural therapy with more traditional techniques to give a more holistic intervention to help improve outcomes. But one thing all of these components have in common is that our evidence is really preliminary, and we need higher level of evidence to show whether these techniques are effective in change. So one further consideration is how we deliver these interventions and assessment. And of course, COVID really escalated our ability to be able to deliver more digital solutions. And certainly this can help with delivering this more to a wider group of people. So just to run through some current examples about how this might work. This is evidence that comes from Amsterdam, which is a system whereby patients online can fill out patient-reported outcome measures. And according to the outcomes of those measures, they are triaged. So for those people that have identifiable problems, some of them will be directed towards more information and advice about how they may deal with those problems. But according to the PROMs, if it cuts off at a level where there's more profound difficulty, then this system then pushes the patient towards the healthcare professional and arranging a consultation earlier for them. So potentially it helps to triage patients to the appropriate place. More recently, though, and certainly with the rise of artificial intelligence, this is an example of how this may help in the clinical situation. So this very early evidence is looking at using the patient concerns inventory, which was devised out of Liverpool. And patients complete the PCI, and then according to the outcomes of that are taken through almost similar to a sort of ChatGPT style of receiving information and picking up on the problems that they've identified in accessible bite-sized ways of delivering this information, using and drawing upon clinically robust evidence, though not large language models which can be inaccurate. And this work has been tested out in a centre at St James's Hospital in Dublin, and it was found to be particularly feasible for those patients during radiotherapy. So this, I think, will be an exciting development for the future. Okay, so finally, I'm now going to move into the late effects of radiotherapy treatment. So what are we terming late effects? Well, this paper that was published quite a long time ago now, I think it's probably approximately sort of 2015, I think always remains with me because it started to hint that actually following radiotherapy, patients can have different trajectories. So some patients may go on to continually improve over the course of time. Some people end up with persistent chronic difficulties. And then there was another group that seemed to emerge that people were doing relatively well and then suddenly started to run into problems. And this really, again, gave me the impetus to follow up my initial PhD cohort 6 years after they'd had treatment to really look at what sort of issues they were having. And it found that equally, you know, there were a lot of people still aspirating by 6 years, and there were some people that had ended up with more problems after a latency period. And more recently, my colleague Diane Selstrom has published this scoping review that has really tried to bring this evidence together to look at what we're calling late radiation-associated dysphagia. It identified that the onset of this was approximately 6 to 12 years after radiotherapy, and therefore these patients were no longer being followed up for cancer surveillance and may actually just be lost to follow-up. And this poses a lot of challenges in how they may find their way back to us. So Diane has also published this consecutive case series just to look at who is presenting with this late radiation associated dysphagia. And she identified that patients are coming with a range of symptoms, not just dysphagia, but also dysphonia, chest infections, osteoradionecrosis of the jaw. So lots of problems, and this can be very complex to resolve. She found that over half of patients had actually experienced a hospital admission, and that more often these patients were coming in via their GP, and a quarter of them had experienced an acute admission. So this is a big problem, not only for patients, their families, but also for healthcare systems. She's also recently published interviews exploring the lived experience of these people. And what I've extracted from this interview data is really a deeper exploration as to how come these patients come to us quite late after a long period of experiencing this deterioration. So one patient talked about this being a really gradual thing, that it sort of crept up on them that they were having swallowing difficulties. Someone else said that they were fine until about 12 months ago, and then they noticed that they were having problems, and then it rapidly deteriorated. And then somebody else talked about, well, actually, they'd noticed this happening about 5 years ago, but were in denial and probably didn't want to come back into our services. And then this one person was having problems when he was out playing golf one day, came home, laid on the couch, went back to work the next day, and then was sent home because he couldn't breathe. And it's not an uncommon occurrence that we may see that patients are requiring a tracheostomy because the fibrosis and the scarring has got so difficult that they can't breathe. So what are we doing to try and address late effects? Well, it's really problematic, and our evidence base for interventions is really in its infancy. One thing we're unsure about is that this doesn't happen to everybody. So who is it happening to? And one of the things that we were delighted by is that the Pathos trial has received additional funding to be able to follow patients up to 10 years. And that might give us an indication about how common late effects might be and who it may be affecting. Similarly, we also have a large cohort study called Head and Neck 5000, which is run out of Bristol. And this again is following patients up predominantly by patient-reported outcome measures to really try and look at the trajectory in the long term. So we'll have more information as time goes by. However, there is also some new thinking around late effects, and I just wanted to bring this up because it kind of makes a lot of sense to me that actually not only are patients coming back to us with dysphagia, but there's a whole range of side effects that people are presenting with. And again, that leads to us finding it really difficult to rehabilitate this group. And this thinking is really about pro-inflammatory markers being responsible for this systemic response and maybe a trigger for the development of late effects. And so this points to actually making sure that we work with other team members that can also address some of the range of symptoms and problems that these patients present with. So trying to put all of those things together now, in summary, what I think we need to be looking towards is certainly preventative approaches. How can treatments designed to cure head and neck cancer be tweaked in order to prevent and reduce functional impairments, to also continue with our core outcomes. So collectively, we can learn more about what influences patient outcomes. We definitely, like many areas of speech and language therapy and medical care, we need more evidence pointing towards effectiveness of interventions and also de-implementing things that aren't effective for our patients. We definitely need to harness the digital revolution, and I think this may, for some patients, provide better access. We need to identify people that are experiencing side effects of treatment, and this is particularly the case in the arena of late effects, and ultimately ensure that our care is fully integrated with other professional groups that can help resolve some of the functional sequelae of this disease. So none of this work would have been possible without a range of people working in this particular area. And this is just some of the people that work in my research group, which is called Living Well After Head and Neck Cancer. And a lot of these individuals have been successful in acquiring funding via the National Institute for Health Research. And certainly the NIHR has supported my clinical academic journey. So I'm just going to go through a couple of slides just to look at what the offer is currently by the NIHR for us. First of all, starting with the Insight programme, which targets either students just about to qualify or graduates that are within 5 years of graduating. And this programme runs across 12 regional centres, and you can certainly find it by Googling the Insight programme as to the centre near you, and it offers stipends and studentships to conduct a research master's degree. So for those people that are clinically qualified and really want to get more knowledge and skills around research, that might be around research delivery, it may be around a clinical academic career, then this offers funding usually for up to 6 months to release people from their clinical time with backfill money to work alongside academics in order to experience and become more skilled in this area. And then finally, the NIHR has an offer which is known as the Academy Research Training Awards, and this ranges from pre-doctoral funding, doctoral and advanced clinical academic practitioner awards, and these are highly competitive but great for supporting people along the way in order to transition to a clinical academic. So that is the end of my slides. I'm really hoping that I have addressed the title, which is about evolving treatments, evolving needs and advancing rehabilitation in the arena of head and neck cancer. So thank you very much for your attention, and I look forward for any questions you may have. Thank you very much.
It was absolutely wonderful, Joanne. Thank you so much, or Joe, I think you prefer.
Yes.
It was really wonderful, and there's lots of wonderful comments and thank yous in the chat. So I'm going to manage this, and Claire, please do chip in if I don't cover everything well. But one of the questions that's just come in, because we have had questions sent prior, which we will go and visit too, but I would like to just address Catherine's presentation. She said, "Thank you for a fabulous talk. One thing I wondered from your experience, we have an ongoing debate at the moment about which time to highlight the potential extent of some of the late effects with certain tumour size locations. Patients have reported different things. Some feel they weren't prepared in relation to some of the extent of the difficulties, whereas others felt they were given enough information. If they were given enough information, it would be too scary and it might not happen. So they're planning some co-production and a focus group to discuss this further. They wondered if you had any thoughts. So there's quite a lot there in that, but
I couldn't agree more with the problem. it's really challenging, isn't it, as to how to give that information, when to give that information. And I think we're working in a murky area because we don't know who this affects particularly. And so it's that balance, isn't it, between knowing how to set expectations accordingly. And certainly that's linked to a poorer outcome if people are feeling that they weren't given the right information or the right level of expectation around that. I think one thing that is critical and something that is certainly on my radar is that very often these patients are coming back to us with really intractable sort of late effects, and so our interventions may help to keep things in abeyance for a little while, but actually that makes it really hard to work out whether they're effective. So one thing I would say is really trying to, which is good practice anyway, let people know how they can re-access services as early as possible, so that we can see them at an earlier point, and that might help actually with giving them something that can help prevent that probably inevitable sort of deterioration. So I don't have a clear answer to that, other than I think co-production focus groups is exactly the right way to go back to the person who to the people for whom this is affecting. One thing that Macmillan Cancer Relief have published is some information about late effects as well, so that actually might be useful to signpost people to. But clearly, if this is affecting people sort of 6 years plus down the line, that's really a challenge. So I think knowing how to re-access our services is crucial to that.
Yes, that's really, really interesting. Thank you. And it sounds like, signposting patients to at least be able to get in touch quickly if they start to have issues is kind of key there. But that's really interesting. Thank you. We've had a couple of questions on the same theme based on what was posted earlier, but also today. So Camilla, just such a brilliant lecture, Joe, really inspirational. And this is the question: with all your experience, what would you have told your early career researcher, clinical academic self?
Yeah, yes, actually, I think I came into that just at the right time, because it was clearly the NIHR really, when did that start? Yeah, my PhD was actually funded as a precursor to the NIHR, so that was a wonderful option for us. So what would I tell my earlier self? I wish I'd probably got into research a little bit earlier on, and hopefully people are now accessing more research training, more academic training earlier on in their career pathway. I think really what has been so helpful to me is finding mentors, champions that support. And invariably, the two champions that I think about in my career have been Professor Janet Wilson and Professor Terry Jones. They have both really opened doors for me. And as a speech and language therapist, without our profession having a lot of clinical academic sort of role models, I'm talking about sort of 25 years ago now. Obviously that has changed. Those people were crucial in supporting me and encouraging me. So I think that's probably been the biggest help to me. So trying to find those champions and mentors early on, I think, is useful.
That's brilliant. And how did you access them and find them early on?
Well, I think certainly I met Professor Janet Wilson via doing my master's, and also because she was a clinical academic, worked at the Freeman Hospital in Newcastle, and so she has always been a great champion for speech and language therapy in ENT anyhow. But it was probably the masters, by her being one of my supervisors during my masters, that really that really solidified that relationship.
Lovely, thank you. Yes, that's the real challenge, isn't it? Getting the balance between the clinical experience and the research experience, and
Yeah,
um,
absolutely.
making sure you get into the research soon enough, but not too soon. Exactly. Lovely. There's lots of questions about national policies and evidence, so I'm going to ask you one of those, and I'll try and cherry pick some of these. So, how well do you feel national policies and evidence support speech and language therapists feeding into the multidisciplinary teams working in this area? And what are the key gaps or barriers and changes you would recommend?
All right. Okay. Well, I think we are fortunate to have a number of sort of guidelines, certainly. And last year we saw the publication of head and neck cancer guidance across the UK that was published by ENT UK. And that's a really comprehensive set of guidance which covers all components of head and neck cancer. There is a specific speech and language therapy chapter in that, but there are other areas where there are other chapters in those guidance that I think will impact on speech and language therapy. So I definitely recommend that as one document to go to. And obviously, the Royal College of Speech and Language Therapists has been instrumental in making sure that we have clinical guidance. Again, this was refreshed last year and is available on the website, and also includes a competency document for those people working with laryngectomy. But we will probably draw upon other competency documents that the college hosts too. So things like tracheostomy, working with tracheostomy, videofluoroscopy, endoscopy as well. All of these will make up part and parcel of what a speech and language therapist in head and neck cancer does. And then we also have which I know Camilla has led on for speech and language therapists, is the Getting It Right First Time document, which really goes into some detail about head and neck cancer services as well, and also is concerned with how we may deliver our services. So that's absolutely essential reading too. I guess it's been a while since NICE has published anything head and neck cancer. So I think it was 2002 we had the Improving Outcomes guidance. So yeah, it's worth a look. And that some things are still relevant to today, I think. I guess what's missing is often how we end up implementing this guidance into clinical practice, because there are huge barriers for us, and hopefully I touched on some of those barriers without being too depressing about how we may address this often quite changing picture as well. You know, so things can move fairly quickly for us. And again, I think I would encourage anyone to sign up for the Clinical Excellence Network and Head and Neck Oncology as well, because this is the way that we can come together and really try and address some of the issues. And I know that we have tried to think about how we can capture the information that is often missing from these documents that are going to be important for us to support our services and protect our services too.
Thank you. That's really interesting. So question from the chat is the question Q&A today. Someone has said, what are important considerations for therapists working in the acute hospital setting when working with survivors of head and neck cancer, specifically when they may be months or years post-treatment for head and neck cancer or admitted for another medical issue?
Yeah. Yes, again, I think this sort of alludes to how people may find their way back to us, doesn't it? And I think perhaps in the first instance, when I started out doing my PhD, there were very few longitudinal studies that reported on outcomes for patients. And so it was really hard to know, to give the information to patients about what to expect, but also to think about at what point might we discharge patients from our services, and think about actually identifying patients who were probably not expected trajectory. And I think this then helped to inform, well, actually, if we know that patients are stabilizing between 6 to 12 months, then we need to think about really trying to get that rehabilitation in early and intensively, and then maybe beyond that, prepare patients for the fact that, well, maybe by about 12 months, this is the time point whereby we're probably not going to see lots more improvement at that particular time. And so it's this decision about when to discharge these patients from an acute caseload, but also, again, it points to when they should come back to us, how, what signs they could be looking out for in order to identify that they may be somebody that's running into trouble, and to come back to us early. And I think that's probably the best we can do with regarding late effects at the moment, is just again signposting them back into our services.
Thank you. That's so interesting. And there's a couple of questions coming through that have a similar theme in a way. So I'm going to pull those together. So Ailish has noticed that one of the challenges they have noticed is that while patients often for primary treatment at a specialist centre, when they experience late effects, they're often admitted to hospitals which don't have specialist specialty provision, and they often don't even have ENT on site. And I think that maps into some of our colleagues from the Channel Islands and far away from specialist centres. They're saying, are there resources or pathways to support people who are living in more remote locations who have to travel far for treatment?
Yeah, absolutely. Because the sorts of symptoms that people may be presenting with, for example, recurrent chest infections or something like that, it may be that their GP, or, sadly, if it ends up in a hospital admission, that being managed by people that aren't familiar with head and neck cancer and the potential side effects of the disease. It's very difficult for them, isn't it? It's probably not going to be uppermost as one of the potential causes as to why they're running into problems. I just think it's a wicked problem to help to resolve, other than trying to make the patient, their family, aware of the potential. And I think sometimes we perhaps just need to be a little bit more specific about how they may go about sort of monitoring their function. And I think this is why Diane's work that has started with interviews to really try and understand how patients are experiencing these symptoms and how they occur, that actually that may go part way to helping this problem, but I don't think I've got any solutions to it just yet. I think it's something that we're obviously all experiencing this problem. It's not going to be a simple solution to resolve, I don't think. And I can understand, head and neck cancer services, they need to be conducted in specialist centres, because evidence has shown that actually the treating clinicians need to have the experience in order to deliver high quality treatments for this group. But that does pose a problem for us in how we may rehabilitate and the access to services.
I suppose there's the potential now, as you were saying, with the wonders of technology, of maybe trying some sort of care pathways out to specialist resourcing that could be provided through telehealth or something similar?
I think there's so much potential there, isn't there?
Mm.
And I think from across the whole of the pathway, this the ability for patients to, because patients ask questions in certain ways, and to capitalize on AI. And also this helps to often patients will say, actually, I received so much information, it was just overwhelming. And so it's no wonder that it's difficult for them to hold on to the information that's been given to them, or it may have been given at a level which was really difficult for them to digest. And so I think AI has got a huge potential, but obviously that comes with risk as well. We really need to make sure that whatever the information they're accessing is accurate and doesn't raise anxiety, because we all know that's the risk with AI, is that actually, it can start leading us to the wrong information. And so currently we are working with a company to try and see how we can address this. But I think maybe late effects, it potentially could be a way forward in helping direct patients.
Yeah, thank you. I mean, there's certainly quite a few questions coming in about expertise coming out to support and train people who are not feeling as specialised, or where their services aren't as specialised to support the service users. So
Yes, and I would really that's a great opening to talk about one of our other PhD speech and language therapists, Laura Jane Watson, who is currently looking at laryngectomy care. And this is a great example of actually, a small number of patients going back out and being discharged from hospital into the community, and the community services, not just speech and language therapists, but sort of district nurses, GPs, really being overwhelmed and perhaps uncertain about how they can best support this particular group of patients. And so she again is really trying to address that issue, and I think digital is probably will be part and parcel of that solution as well. So yeah, that transition point, which can be hugely scary for patients when they're leaving the sort of safety, if you like, of a specialist head and neck cancer ward, and transitioning to their own homes. Yeah, we need to really address that issue.
oh, thank you. I think it would be really useful to maybe talk a little bit about how therapists can support cancer survivors with emotional needs and distress that may arise during the rehab, because I think that's something, obviously, with the CBT project that you were talked about. I'm sure it'd be interesting to hear your thoughts about that.
Yeah, absolutely. And again, this was something that came out of my PhD, is just the profound difficulties that people were experiencing with living with functional impairment, particularly swallowing difficulties. And yet we didn't really have evidence base around how we would address that. Yes, we had things around exercises, maneuvers and things like that, but that's addressing the impairment, isn't it? And we would hope by addressing the impairment that things may improve for patients, but I think other things need to be addressed alongside that. So that then led me into looking at whether we can use some of the techniques around cognitive behavioural therapy and intertwine them, and for that to be delivered by speech and language therapists, which it did demonstrate that could be done, and that did lead to a meaningful change in patient reported outcome measures. But I think certainly along the way I used other techniques like acceptance and commitment therapy as well. I think that has got potential for this particular case group, especially as people and their families are having to adjust with lifelong chronic side effects of treatment, and a side effect that probably isn't going to improve much more. So how do you live your life as best you can in the long term? But there are other things that I think people have got involved with along the way. So certainly a lot of our team are trained in motivational interviewing. And I think, again, this can help with, engaging with rehabilitation, working with the patient in order to try and think about what is motivating them to work alongside and conduct things that are actually quite difficult for patients to do. I think we're often asking people to a big ask in terms of rehabilitation. And also fundamentally, I think to have really good listening skills, communication skills, and very often in head and neck, people have got on to do further training in this area. Person-centered counselling is a great place to start, I think.
Yeah, I mean, it sounds like such a huge thread through the whole piece for the patients. So vital. So it's really helpful. Thank you so much. I realise we're now coming towards the end of our allotted time. So I'm aware that we want everybody to complete the evaluation. So it might be helpful to pull up the slide so that code is up and that participants can complete that. But I'd like to hand over to Claire to ask maybe a final question of you, Joe, and just to say from my behalf and part of IJLCD, thank you. That was amazing, and I know Claire will close. But thank you so much.
Thank you very much.
Thanks, Jill. There are still a few questions, Joe, and we're aware that we've taken a big chunk out of your day already, so we don't want to give you a lot of questions, but they might come up actually in the evaluation, which you will also have access to. People are asking about some of the specific things, like how often should follow-up happen? How are late effects actually defined? Is it sort of 6 months, 12? Is there a known period for it? And so maybe while people are filling in their evaluation, you could address those two sneaky things. And yeah, and once we've done that, then I will actually draw us to a close.
Yeah, sure. So follow-up. Yeah, again, we probably haven't got any set guidelines about the frequency of follow-up. I think one thing that is probably universally agreed, is that patients need to be seen pre-treatment. So I think that's crucial, not only to do a really good assessment and to establish their baseline, but also to provide information about what you're expecting their treatment and how that will impact on functional. So decision regret is a difficult thing for patients, and part and parcel of that is informing them as best you can about the range of possible outcomes. And also for some patients, they now are given options as to different treatments that they could receive, either surgical or non-surgical techniques. And so sometimes patients will trade off, what that might mean for their function according to which treatment they select. So again, that is an important part of a speech and language therapist's role. In the post-treatment period, I think we probably need to be quite nuanced in what we offer. And again, I think this is where, going back to the evidence base, looking at the trajectory about what the potential outcomes might be, and according to the treatment, because they'll just be very different. One thing that I think has changed is that with the radiotherapy and chemoradiotherapy, we're seeing a sort of like long-term recovery from that. And then when robotics came in and more laser therapy for the minimally invasive surgery, we then needed to think about providing more intensive help in the immediate post-operative period. So that just illustrates we have to build this around the patient and the evidence that we have. and help to direct us in terms of follow-up. So that's that question, I think.
That is.
And we returned to the topic of late effects, wasn't it, Claire?
Yeah.
That second bit. And I think this Q&A is just reinforcing to me how much more work we need to do in this area. You know, that there is, Australia have published some work that shows actually we should do closer surveillance. We know that there are late effects clinics that are cropping up. Some of those are led by people other than speech and language therapists. But I think what is probably becoming a bit clearer is that we may not always be talking about the same thing. You know, late effects to me is different from chronic side effects, which have been persistent post-treatment. Late effects to me are the ones that have actually probably gone on to make some level of recovery, and then something gets switched and they start to deteriorate. So I think collectively we just need to do more work in the area and share what information we can extract from, as already mentioned, co-design and focus groups. I think that's really useful to hear from the patient.
Yeah. Thank you so much. I always think it's a sign of a good presentation when there's more questions than we have time for. So you've clearly sparked some thoughts and challenges for people, and given those people who are working particularly in this area a real chance to sort of critique their own work and their own practice. You have provided an immense amount of resource and knowledge, and thank you so much for sharing it with us. We are extremely grateful. Thank you from both Jill and I, as she said, on behalf of the journal, and also sitting within the Royal College. This has been a real treat for us, and thank you so much. We're absolutely delighted, and all of the comments coming in from people have been saying the same thing. So thank you again, Jo. We really appreciate it.
No, that's again, it's been really enjoyable, and thank you for all the kind messages. That's really appreciated, and also really insightful questions. I don't propose to know all the answers to it, but I think it's really useful as a researcher to think actually we are on target and really trying to progress things in this really exciting area of speech and language therapy.
Yeah, absolutely. Thank you so much.
Thank you.